Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, in UAE time. I welcome everyone and all of you, and thank you for attending this session, one of the sessions for neuromuscular series, which we are doing from the end of last year. Our talk today will be focused on myasthenia gravis and would have a flavor of young and expert doctors here. And today, the talk or the meeting will be chaired by Dr. Salama Karmstaji, who's a specialist neurologist in Rashid Hospital, DHA, and she is our future neuromuscular specialist. Dr. Salama, please go ahead and
I'm Dr. Sam Karamstaji. I'm pleased to have you all here this evening to join us Myasthenia Gravis webinar. We are grateful for our speakers today that will be able to share trusted and evidence-based information on Myasthenia Gravis. Today's webinar will be about update and diagnosis of Myasthenia Gravis will be given by Dr. Yassir, and update and treatment of Myasthenia Gravis, which will be done by Prof. James Howard. In advance to their presentation, and we'd like to thank each and every speaker to their time and expertise. Before we start, I would like to mention that we have muted all participants, but I welcome you to type any question or comment for today's session and the Q&A answer. We have a little time at the end of today's webinar for question and answers. First, we have Dr. Yassir Malik, a senior specialist in Rashid Hospital. Dr. Yassir graduated at King Edward Medical University, and he did his neurology board from College of Physician and Surgeon in 2011. Welcome, Dr. Yassir.
My main talk would be about the myasthenia gravis, its diagnostics. Myasthenia gravis is basically a post-synaptic antibody-mediated T-cell dependent immunological disease, and its annual incidence is approximately 7 to 23 new cases per million, prevalence of approximately 70 to 320 per million of the population. And it has been noticed in recent studies that since mid 20th century, the incidence and the prevalence is on rise for the myasthenia gravis. I will be discussing myasthenia briefly about the basics, facts and figures of myasthenia, and then I will be going towards the diagnostics. So myasthenia is a bimodal, has a bimodal onset, as you can see in this graph. It's showing the two humps. The first one is in the second to third decade, and the second one is the first one is second, third decade, and third one is the fifth, sixth, and seventh decade. As it's evident here that the first one is more prevalent in the females, and the second one is the more prevalent in the males, and that's why we see more commonly the young female patients in our clinics. So there is another form of myasthenia, that is postpartum myasthenia. That is probably during the pregnancy, the immunological systems have been suppressed, and all of a sudden after the pregnancy is over in the postpartum, some of the patients are having subclinical disease, as the system is, immunological system is, it goes on surge just after pregnancy, though it appears just after pregnancy, but it is having relatively a better prognosis. Then there is a neonatal myasthenia that happens in 10 to 20% of neonates, especially in the neonates of the myasthenic mothers. That is because of the transmission of myasthenic antibodies across placenta to the neonates, and it's having a relatively very good prognosis. It remits usually in a few weeks. Okay, so the diagnostics would be in two parts. The first part is the clinical side. You know, the myasthenia is most important thing is the history and examination, and then we'll go towards the laboratory. The most important thing is the history and examination of myasthenia. Myasthenia patient really most of the time presents in the younger age, and it is with the fatigability, ocular features like diplopia, blurring of the vision, ptosis, or there is some change in the voice, or there is chewing difficulty or fatigability that presents with this. I want to mention one thing, particularly in this weakness. When the patient comes with the weakness is really fluctuating. It's not typical. It's not the continuous weakness that is going throughout the day, like the other neurological disorders. It is fluctuating. Like it would be usually in the morning, patient would be very much normal, would be having very minimal weakness, but as the day passes on, the weakness would increase. And muscle fatigue is there, but unlike other fatigue syndromes, it is very much focused. It is specific to certain muscles, especially the muscles who are doing the repetitive movements. It's not generalized like generalized fatigue syndromes. And some of you see two type of myasthenia in general. One is ocular myasthenia, and second is generalized myasthenia. Ocular is presenting mainly with ocular features only. Sometimes you may see some of the atypical features with ocular myasthenia, like isolated oculomotor nerve neuropathy, intranuclear ophthalmoplegia, or vertical gaze braces. You may think of something else, but myasthenia should still be kept in the mind. Now, the patients who are presented with the ocular myasthenia, almost 50% of such patients, they transform into generalized myasthenia in the 2 years. But what are the factors that can predict that this patient would go into generalized myasthenia or not? That unfortunately we don't have. So, some particular features in the history, then generalized neurological examination is important. Then I will show you some particular signs about the myasthenia. First one is the curtain sign. That is usually positive in the patients who are having asymmetrical ptosis, or that is ptosis only in the one eye. Like you can see in the first figure on this side, this lady, there is significant ptosis on the left eye, and there is very minimal ptosis in the right eye. So what happens that in order to maintain a sustained posture of the eyelid, there has to be a continuous release of acetylcholine in myasthenic patients. So there's Hering's law that if there is sustained release of acetylcholine, that would affect on the normal as well as on the abdominal eye. So what happens then when we hold with the hand the abnormal eye of the patient, and this sustained release of acetylcholine that was supporting this posture, that goes away, and as it was giving some force to the normal eye or less ptotic eye also, so that support is withdrawn and suddenly that goes down. So you see the normal eye of the less ptotic eye goes down. That is called curtain sign. And there's another one that is called Cogan's sign. In Cogan's sign, usually the patients who are having neuromuscular junction blockade, or their transmission is somehow delayed, for any moment they have to accumulate a source of acetylcholine, then they will do some movement. So when you're seeing a patient, you ask the patient to look down and then to bring your eyes to the primary gaze. So that acetylcholine sources which have been accumulated, that will surge, that will act all at sudden, and the patients, instead of coming to the primary gaze, would have the overshooting of the eyes. So as you can see in this panel, the A is look down gaze, the B you can see there is a feeling of overshooting in the right eye, and then C, after that the patient comes to the primary gaze. So this overshooting is called Cogan sign. That's all about the clinical side. Now we'll do there are certain tests on the clinical sides. Most important, the easiest one is the ice pack test, that is carrying the sensitivity of 80%. If you put ice pack on the ptotic eye for almost 1 minute, you can see there is relief of the ptosis. That is probably the release of the acetylcholine that is potentiated. Second one is the tensilon test, that is done by the adrophonium. Adrophonium is one of the acetylcholinesterase inhibitors. It's short acting and relatively safe. It prevents the breakdown of the acetylcholine into the choline and acetate. When you give that, blocks acetylcholinesterase, and it increases the more amount of acetylcholine that improves the ptosis of the eye or any clinical finding. So adrophonium is given in 2 milligram bouts intravenously. You give for 2 milligram for once, then look for the response, then you repeat it after every 60 minutes up to the maximum dose of the 10 milligram. Its sensitivity is 80 to 90%. And we have to be cautious about the muscarinic effects of the adrophonium, especially in the elderly patients and the patients who are having cardiac disease or who are having bronchial asthma, because it can trigger the cardiac arrest, cardiac blockade, or bronchial spasm. Now going towards the laboratory side, the most important thing which are commonly carried out are the AUTO-ANTIBODIES. So approximately 90% of the generalized myasthenia, that is seropositive. The, the patients who are carrying either acetylcholine receptor antibodies or anti-MuSK antibodies, these are termed to be positive. The remaining who lack them, they are called seronegative. Okay, so in those who are having purely ocular myasthenia, the sensitivity of acetylcholine receptor testing is relatively lower, detectable in approximately 50% of the patients. And the ocular myasthenia patients with MuSK antibodies are very rare. They are usually presenting, most of the time they're presenting with acetylcholine receptor antibodies. Sensitivity of antibodies varies by the type of myasthenia gravis. So especially if it is generalized myasthenia, then specificity is very high for acetylcholine receptor antibodies. For the generalized antibodies, for the generalized myasthenia gravis, acetylcholine receptor antibodies would be positive in 85% cases. MuSK would be positive in the 8%, and LRP, that is low range lipoprotein receptor protein 4 antibodies, that is positive in 1% of the patients, and remaining 6% would be seronegative. So as I said before, the patients who are lacking the initial two, the acetylcholine receptor and the MuSK antibodies, they are termed as seronegative myasthenia gravis. So in this picture, this is a post-synaptic terminal picture. You can see the array of the multiple molecules here. Acetylcholine receptor is the one that is anchored in the membrane with the help of repsin. So any antibody that is against acetylcholine receptor or repsin, that would be giving the picture of myasthenia that is resembling the acetylcholine receptor antibody positive myasthenia. And MuSK antibodies, they are associated with the dog anti-dog. So anti-dog antibodies or anti-MuSK antibodies, they would be giving the similar picture that of like anti-MuSK positive myasthenia gravis. Most of the time it is generalized myasthenia. Very, very rarely it is ocular that is carrying the MuSK antibodies. And the third is LRP4. There's a molecule called agrin that is anchored along with that, and antibodies against agrin or against LRP4, they would be giving this kind of myasthenia, and that would be very mild form of disease. Now, talking about the antibodies one by one, first of all, acetylcholine receptor antibodies. Usually in the assay, we can look for three kinds of antibodies: the binding, blocking, and modulating. But the binding is most important. And most commonly commercially available antibodies are the binding antibodies. Whatever usually we are checking, that is a binding antibodies, and it's checked by the radioimmunoassay, and it's highly specific for myasthenia gravis. The assay for the binding antibodies is most sensitive. Essentially, all the patients with myasthenia gravis with thymoma are seropositive for binding acetylcholine receptor antibodies. The negative predictive value of thymoma in the absence of acetylcholine receptor is very high. It's 99.7%. The patients who are don't carry acetylcholine receptor antibodies, the thymoma, presence of thymoma is highly unlikely in these patients. Acetylcholine receptor antibody titer poorly correlates with the severity of disease. So if somebody asks me that, doctor, I started the patient on the anti-immunomodulator or anti-acetylcholine receptor inhibitor, acetylcholine esterase inhibitor medication, do I need to check for the level of the antibodies in order to get the response whether my patient is responding to this medicine or not? So the answer is no, because these things don't predict the therapeutic response. Very rarely, these antibodies can be positive in the Lambert-Eaton myasthenic syndrome, motor neuron disease, and polymyositis. The second one is the MuSK antibodies. MuSK antibodies, they are present in 38 to 50% of those patients who are lacking acetylcholine receptor antibodies. There are particular features about them. They can onset in any age. There's female preponderance, and there are two very important syndromic presentation of such kind of myasthenia. One is oculobulbar. They present with the diplopia, ptosis, dysarthria, and nasal twang of the voice or hoarseness of the voice. But there is no pure ocular myasthenia in this. And sometimes you may rarely see the tongue and facial atrophy in this kind of myasthenia. Second form that is really you can see in the clinic, that is restricted myopathic pattern with a prominent respiratory or the proximal muscle weakness. especially the neck extensors are weak in this kind of myasthenia. As anti-MuSK antibodies are not associated with the thymic pathology, so role of thymectomy is uncertain. Ocular features are common in anti-MuSK antibody myasthenia, may be presenting feature also, but the ocular myasthenia is very, very rare in this kind of myasthenia. Third one is LRP4 antibodies. They are part of acetylcholine receptors required for acetylcholine-induced activation of MuSK and acetylcholine receptor clustering and NMG functioning. And approximately 10% of the patients who are seronegative for both acetylcholine receptor and the MuSK antibodies, they would be carrying such kind of antibodies. The patients who are carrying such kind of antibodies, they are relatively younger, they are more often females, and they are having milder form of disease. There appears to be no association with the thymic pathology once again. So role of thymectomy is again uncertain here. So there are certain new kind of antibodies having some significance in some contexts that I would be mentioning. These are called anti-striatal antibodies. So striated muscle antibodies. This class of antibodies against component of the skeletal muscle, they include the titin, ryanotine receptor antibodies, myosin antibodies, and alpha-actin antibodies. They're present in 70 to 80% of the patients who are having myasthenia, especially the patients who are younger than 40 years. And 30% of those adults who have myasthenia but don't have thymoma, they would be carrying them. And 24% of the patients who are presenting with thymoma, but they don't have myasthenia, they would be carrying this also. So the significance, particularly for these antibodies, are that unlike the other antibodies, these antibodies somehow can predict the clinical course of the disease. Like if you ask me that if I started the patient on the treatment and I want to check the titer of the antibodies to predict the therapeutic value of these, will the patient benefit for this or not? So these antibodies somehow they can predict the benefit in the future. Then there is one important and new antibody that is clustered acetylcholine receptor antibodies, also called low affinity acetylcholine receptor antibodies. These are seen in 50% of seronegative myasthenic patients. They are done by special cell-based assay, and they are useful thymoma markers, especially in the younger population. They have positive predictive value for thymoma of 30 to 35% and very high negative predictive value for the thymoma. The new antibodies, KB1.5 and AGRIN, are under assessment, and clinical relevance is known very little at the moment. Maybe in future we'll be able to get something. So as I mentioned before, the patients who lack acetylcholine receptor and anti-MuSK antibodies, they are called seronegative myasthenia, and they account for 6 to 12% of the patients. And they are having relatively milder form of disease and having better prognosis. This is the summary of whatever I said so far. The three antibodies are very important, currently commercially used. Most common one is the acetylcholine receptor antibodies. They can present in two forms. The first one is early onset lesser than 50. Second one is a late onset above 50. The earlier onset, they are associated with thymic hyperplasia and female predominance is there. And the late onset, the male predominance is there. They can present with both ocular and generalized myasthenia. The MuSK antibody, they are usually presenting lesser than 50, and female predominance is very, very high in this. There is no relation of thymic pathology, and they are usually presenting, most of the time they present with the generalized myasthenia. LRP4, they can present at any age, no relation to thymic pathology, and they are having very mild form of disease. This is one of the articles that was published by our department under umbrella of DHA. It's the role of Myasthenia Gravis autoantibodies as a predictor of myasthenia crisis. I want to take your attention to this box that if we have tabulated acetylcholine receptor antibodies, MuSK antibody myasthenia, and seronegative antibody myasthenia. The presentation Oslerman's classification you can see for the first two panels, like for the acetylcholine receptor antibody panel and the MuSK panel. The milder form is very high, it means into 90 to 85% would be the class number 1 to class number 3. But the severe form is very little. But in seronegative, all are having milder form. They don't have the high prevalence of the higher Osserman class at presentation. But most important thing which I have to show you here is the myasthenia crisis that happens in 61% of the patients carrying with the acetylcholine receptor antibodies, and 100% of the patients with the MuSK antibodies, and only 33% of the patients who were seronegative. So again, the disease form would be very severe for the MuSK specific antibodies, and it would be moderate to severe for the acetylcholine and milder for the seronegative patients. Second part of the talk that is on from the lab, that is electrophysiological testing. So we start with the nerve conduction studies, and then two important tests we do for this context, that is RNS and single fiber EMG. RNS is carrying 75 to 80% sensitivity and specificity of 44 to 65%, and single fiber is 95% sensitive and 100% specific. Before going to that, I have to show you some physiology of conduction of the impulse across the neuromuscular junction. When the motor nerve fiber action potential arrives at the nerve terminal, it triggers the opening of the calcium channel. Calcium channels, it moves into the presynaptic terminal, and it activates the SNAIL proteins, and it elicits the acetylcholine vesicle release that increases the acetylcholine in the cleft of the synapse in the neuromuscular junction, that acetylcholine binds to the postsynaptic terminal acetylcholine receptors, that triggers the sodium channel opening there, and this generates the end plate potential. And when end plate potential is generated, if it qualifies at the threshold, it elicits a muscle fiber action potential. So these are the sequences of events which are needed to have a muscle fiber action potential. This is electron microscopic picture of the postsynaptic terminal. You can see some dots. They are arrayed in the parallel lines. These are the acetylcholine. It's presynaptic terminal, showing the acetylcholine vesicle arrayed in the parallel lines. So each vesicle contains thousands of acetylcholine molecules. Acetylcholine basically pools are categorized into the primary source, secondary source, and the tertiary source. The primary source is the immediately available acetylcholine, and the secondary is in the vesicles. They are behind. They are in reserve, and tertiary is that is behind that. So if the muscle fiber is firing above the frequency of 0.1 hertz, it produces serial decline in the acetylcholine receptor in first 4 to 5 impulses. Then the other sources like secondary and tertiary are mobilized, and that causes the stability of the end plate potential. So if these are not there, or somehow there is delay in that, then the end plate potential will not be stabilized. So that will give us positive finding in RNS and the single fiber EMG. And if the firing rate is very high, like 10 to 20 hertz, that gives a postsynaptic calcium release, and that will trigger, that will potentiate the acetylcholine release, and that would give the muscle fiber action potential. There are thing called safety factor. The excess end plate depolarization beyond threshold is needed to generate a muscle fiber action potential. This safety factor ensures that all the nerve fiber action potential, they are coming to the presynaptic area, that should be transmitted to the postsynaptic area, and that should generate a muscle fiber action potential. This safety factor is determined by two things. Number one, there should be sufficient release of acetylcholine. Number two, there should be sufficient responsiveness to the acetylcholine, like the number, density, and functionality of the acetylcholine receptors should be very good. So I want to take your attention towards this diagram. The upper panel you can see here, there in the upper half, there are the action potential that is coming from the nerve fiber action potential, and there is a line that is called threshold. And in the lower part, there is motor fiber action potential. So above threshold, the power or the strength of the nerve fiber action potential that goes above threshold, that qualifies, or that is ensured by our safety factor. And these who are going above the threshold, these are qualifying for the generation of the motor fiber action potential, and that all the nerve fibers who are going above that, they are generating a motor fiber action potential in the lower part of the upper diagram. But coming back to the lower diagram, the first three, they are going above the threshold, so they are generating a nerve fiber action, they're generating a muscle fiber action potential. But the last four, they are not going beyond the threshold, so they are unable to generate any motor fiber action potential. This is called blocking. So this delay or blocking is highly important in our electrophysiological testing. So coming to our repetitive nerve stimulation, we initially stimulate at the low frequency 2 to 3 hertz, and we give 4 to 5 stimuli, and we see two type of response. Number one is post activation exhaustion. Number three is that is seen. Sorry, after that, if we did not get a sufficient response or stable or reproducible response, we go for exercise, and after exercise we see two kind of response. One is post activation exhaustion, and second is post activation facilitation. If the amplitude of the following impulses in the fourth, fifth stimuli that drops down, that is called the post activation exhaustion. So that is we get the decremental response that we can see in the upper part of the figure, and it is positive in the myasthenia. And if it is increased, the amplitude of the following contractions or following response in the RNS, that is called the post activation facilitation. This response is really found in the Lambert-Eaton-Myasthenic syndrome. So our protocol of doing RNS in myasthenia is that initially we stimulate at low frequency. We give 5 to 10 stimuli, and if we get about 10% response, that is very good. We repeat it after that to see the reproducibility. If we do find the reproducibility, that means our test is positive in this muscle. But if it's not, then we go for isometric exercise for 30 to 60 seconds, and then we stimulate it every 30 to 60 minutes for 5 minutes, and we get for the post-activation exhaustion. If it is positive, about 10% amplitude decrement is there, and it is positive. The test is positive, and it is shown usually in 75% of the abnormal muscles in myasthenia, especially in the shoulder and the proximal muscles. The second part is of the electrophysiological, the second most important thing is single fiber EMG. This diagram shows you three types of needles: the single fiber needle, concentric needle, and the monopolar needle. The difference between these needles is that single fiber is having one monofilament only, and it is opening, contrary to the others, it's opening to the opposite side of the bevel or the tip of the needle, and it is having very small field of like hunting the muscle fiber contraction or muscle fiber, like picking up the muscle action potential. So why this small field? In fact, we need that because we don't need a lot of muscle to check that. We need only two fibers contracting together, which are supplied by the same nerve to check for the jitter. What is jitter? Jitter is variability of the time interval between the action potentials of two muscle fibers. They are supplied by the same nerve. So that is the difference of latency basically. And if someone is conducted but it is delayed, it is called jitter. But if someone is not conducted at all, that is called blocking. So that is very important. One important thing I need to mention is that if the patient is on treatment of acetylcholine receptor inhibitors, that would not impact on single fiber EMG. So this diagram shows off the fiber density. Fiber density is also important. While inserting the needle, we have to see how many fibers we are recruiting. Basically, this procedure is very much time consuming, and it is very much operator dependent. We have to twist the needle many times. We have to hunt up the fibers which are suitable for this study, for the jitter I mean. So there you can see three things in this diagram. This is the best for the fiber density. Only 1.5 or 2 fibers you can see they are visible there. We can check in the fiber density here. This is increased fiber density. It is too much. It's not good for us. This is reduced fiber density. It is not good for us because it's reduced. But when we are able to find out two consecutive or two muscle fibers in the approximation, that is very good to detect a jitter. Now, I already told you what is jitter. Now, what do we read in this? We insert the needle in particular muscles. First of all, we have to select the muscle which is either most weak or proximal or bulbar or trapezius or deltoid, which is proximal muscle that can give us good response, or facial muscle, sometimes frontalis, which can give us good result. We have to select the muscle, then we have to insert the needle and record that. And we have to assess at least 20 fiber pairs, and each fiber for each set of pair we have to get the 100 contractions. We have to check 2 to 3 muscles, and if we find at least above 3 pairs out of 20, or 10% of the 20 pairs these are positive, there is some delay, there is some jitter, or there is some blocking, that means our result is positive for that muscle. So how do we claim that our result is positive for that? In the computerized program for single fiber EMG, we check for MCD. MCD is the mean difference of consecutive discharges. That is, 2 muscle fibers are discharging, so 2 consecutive discharges. We have to see the latencies of them for the consecutive discharges. So in the upper panel, you can see this muscle is saying first discharge very good, second discharge is little bit, it is good. So MCD is 28 microsecond, that is within normal range for that, and it's normal. The second one, you can say, see here, first one is good, okay, but the second one is very much delayed. It's very much disintegrated. It's not united together. It's not close. The latencies of different firing is different. So MCD, the calculated is 1818 microsecond. That is more than the given normal value, and there is 20% blocking also. So this test is positive for the neuromuscular junction. The last thing which I would go for is the CT chest imaging. That is CT chest or MRI chest. CT chest we are doing in the most of the time in our settings. Acetylcholine receptor for antibody positive Myasthenia Gravis. About 70% of such cases they are having thymic abnormalities. 85% would be having hyperplasia, and 15% would be having thymoma. As you can see, this graph has been taken from one of the studies from the American Academy of Neurology. Green Journal of American Academy of Neurology. So if you can see the first peak, it is showing hyperplasia, and it is most common in the 3rd and 4th decade of life, and it is most common, most prevalent in the females as compared to the males. And as per this study, thymoma is also more prevalent in females, but that is in the 5th, 6th, and 7th decade, the thymoma. But certain other studies, they claim that the thymoma is more common in the males. I think that would be the end of my talk, and I would be happy to take any questions.